I'm Dr. Brad Westwood, and believe me, I've spent more hours than I can count in an operating room. More than 2 decades seeing thousands of cases and making decisions that change lives. But today I'm not talking to you as the surgeon. I'm talking to you as the son, because there are 5 surgeries that in most cases I would never recommend to my parents. And the reason isn't as obvious as it seems. It's not just about their health. It's about a silent trap that activates after age 65. Before we go any further, I want to ask you something important. If you're watching this video, you're already taking a step that many people don't. You're taking control of your health and the health of your loved ones. That means something. But here's the thing. YouTube doesn't always show my videos to people who need them most, unless you're subscribed. I make these videos because I believe everyone deserves honest medical information, the kind of information I would give my own family. So if you find value in what I share, if you think this information could help you or someone you love, please hit that subscribe button right now and turn on notifications. It takes 2 seconds, it's completely free, and it helps me reach more people who need this information. I don't have a big marketing team. I just have you and this community we're building together. Okay, let's get to it. I know the operating room like the back of my hand. I know the good it can do, relieve pain, correct a problem, even save a life. But I've also seen how procedures that are a walk in the park for someone who's 40 become a minefield for someone over 65. The risk doesn't just double or triple. In many cases, it skyrockets alarmingly. And this happens regardless of whether your parents run marathons at 70 or need help getting up from the couch. In this video, I'm going to do something few surgeons dare to do. I'm going to open the doors of the operating room, but from the perspective of calculated risk, and above all, from the love of a son. I'll reveal what these 5 surgeries are, why the danger increases so dramatically after 65, and most importantly, I'll give you the safe and effective alternatives that exist, alternatives I discuss with my patients, and that I would insist my own family consider before thinking about a scalpel. Because sometimes the best surgery is the one we manage to avoid. Stay with me because this information can make the difference between a full old age and a cascade of complications. If you're ready to learn which surgeries to avoid after 65, write surgery in the comments right now. What makes surgery dangerous after 65? Before we jump to the list, you need to understand a concept that for geriatricians and surgeons is almost more important than age: frailty. Forget for a moment the number on your ID card. Frailty is a medical term that measures the reserve your body has to withstand physical stress, like surgery. Think of it this way: your body is a battery. When you're young, it's at 100%. You can pull an all-nighter, get stressed, and the next day you're good as new. Over the years, that reserve drops. Maybe you're at 70% or 60%. It still works perfectly in your daily life. But if you suddenly face brutal energy expenditure like major surgery, the battery can completely drain. Frailty doesn't always show. We measure it with simple tests like grip strength or walking speed. A 75-year-old person can be incredibly robust, while another 68-year-old can be frail. And here's the key: frailty predicts post-operative complications much better than age. We're talking about post-operative delirium, that terrifying confusion after anesthesia, infections, muscle loss that leaves you bedridden, and recoveries that become eternal. And this brings me to the second crucial point: the abysmal difference between scheduled surgery and emergency surgery. Scheduled or elective surgery gives us time. We can evaluate the patient, optimize their health, discuss options. Emergency surgery is chaos. It's the difference between landing a plane on a sunny day and doing it in the middle of a hurricane. Mortality and complication rates in emergency surgeries in people over 65 are astronomically higher. If there's one thing I want you to remember from this video, it's this. The biggest mistake an older person can make isn't having surgery. It's waiting so long that a manageable problem becomes a deadly emergency, because diseases don't usually disappear on their own. They progress silently until the bomb explodes. Now that you understand this, frailty, and the danger of emergency, you're ready to see why these 5 surgeries are on my blacklist. If you're understanding why emergency surgery is so much more dangerous, write emergency in the comments. Surgery 1. Emergency colon surgery. Let's start with one of the biggest and most feared abdominal surgeries, colectomy, meaning removing part or all of the colon. The common problem: why would someone need this? For several reasons. Colon cancer, diseases like Crohn's or colitis, or something very common in old age called diverticulitis, small pouches in the colon that become inflamed. In many cases, surgery is necessary and saves lives. The problem isn't the operation itself, but the when and how. The hidden risk for people over 65, a scheduled colectomy done by laparoscopy, small incisions, has manageable risks. The disaster occurs when it becomes an emergency. Imagine one of those diverticula perforates or a tumor blocks the intestine. Intestinal content full of bacteria spills into the abdomen, causing peritonitis, a massive and deadly infection. At that moment, the patient arrives at the ER with excruciating pain and in shock. There's no time for preparations. You have to open the abdomen wide, clean up the mess, and remove the damaged piece of colon. For an older adult, this is an earthquake. The statistics are blood-chilling. Mortality in high-risk emergency surgeries can exceed 7% even in non-frail patients. But if the patient is frail, that figure skyrockets, reaching in some studies an alarming 25.8%. 1 in 4 doesn't survive. Complications quadruple. The body simply can't handle the double blow of infection and such savage surgery. I remember Roberto, a 78-year-old gentleman, active, who took care of his garden and played cards. He'd had vague discomfort for months, constipation, diarrhea, sometimes a bit of blood. He chalked it up to things of age. His family insisted, but he let it pass. One night the pain was unbearable. He arrived at the ER with his abdomen like a stone. He had perforated colon cancer. He survived the surgery, but the cost was terrible. 3 weeks in ICU, pneumonia, lost all his muscle mass, and ended up with a colostomy, a bag for stool. The independent man who entered the hospital never returned. He died 6 months later. The tragedy is that if we had detected that cancer 6 months earlier with a simple colonoscopy, the story would be different. The safe alternative. The alternative is prevention, and it's incredibly effective. Colonoscopy is your best friend. Starting at 45 or 50, everyone should get one. It allows us to see the entire colon, and most importantly, remove polyps, the precursors of cancer, before they become a problem. It's a safe procedure with sedation that can literally prevent cancer and devastating surgery. Roberto's story could have been like Rosa's, my 72-year-old patient. In her routine colonoscopy, I found an ugly polyp. We removed it right there. The biopsy confirmed very early cancer, completely cured. Rosa continues enjoying her grandchildren without scars or operating rooms. Eat well and move. A diet rich in fiber, fruits, vegetables, legumes, and low in processed meats reduces the risk of colon cancer and diverticulitis. Exercise, like a 30-minute daily walk, is also key. Don't ignore the alarms: blood in stool, persistent change in bowel habits, abdominal pain, or unexplained weight loss. None of that is normal at any age. They're signals from your body. Listen to them. My advice, what I would give my parents and give you: don't be afraid of colonoscopy. Be terrified of emergency colectomy. Schedule that checkup. An outpatient procedure isn't worth avoiding, one of the deadliest surgeries that exist. Surgery 2. Perforated ulcer repair. The second surgery on my blacklist is another abdominal drama: repair of a perforated stomach ulcer. The common problem: an ulcer is a wound in the lining of the stomach or duodenum. Main causes: a bacteria called Helicobacter pylori, and especially in older people, chronic use of anti-inflammatories like ibuprofen, naproxen, or aspirin for arthritis pain. These medications destroy the stomach's protective barrier. The hidden risk for people over 65: most ulcers heal with pills. The deadly danger appears when the ulcer isn't treated and perforates the stomach wall. Boom. Gastric acid spills into the abdomen. Patients describe it as a stab wound. It's brutal chemical peritonitis that becomes an absolute surgical emergency. The patient arrives in shock and mortality is extremely high, with figures that in the highest risk groups can be similar to emergency colectomy, exceeding 25%. An older person's body can't handle that level of trauma and infection. Post-operative delirium is almost the norm, and recovery is hell. Think of the ulcer as a volcano. While it's smoking, burning, pain, we can control it. If you ignore it, it erupts, perforation, and we face catastrophe. I remember Juan, 72 years old, taking ibuprofen daily for his knee without stomach protector. He started with burning, but calmed it with antacids. One day, he felt the worst pain of his life: perforated duodenal ulcer. Surgery was difficult. Although we closed the hole, infection had spread. He spent weeks in the hospital, developed kidney failure and lung problems. He got out, yes, but weakened, dependent, and without the vitality he had. The safe alternative: the good news is this surgery is in the vast majority of cases 100% avoidable. Miracle medications, PPIs, drugs like omeprazole or pantoprazole are incredibly effective. They reduce stomach acid and allow the ulcer to heal. If the cause is H. pylori bacteria, antibiotic treatment eliminates it at the root. 90% of ulcers heal this way without surgery. Beware of anti-inflammatories. If you're over 65 and take anti-inflammatories regularly, it's mandatory to talk to your doctor. They'll prescribe, along with the anti-inflammatory, a gastric protector. That simple pill can save your life. Upper endoscopy. If you have persistent symptoms, burning, pain, black stool, your doctor will order an endoscopy. With a camera, we see the stomach, diagnose the ulcer, take biopsies, and detect bacteria. Juan's case is the opposite of my patient Manuel, 79, also with arthritis, also with anti-inflammatories, but his doctor prescribed omeprazole from day one. When Manuel noticed dark stool, he didn't wait. He called me. We did an endoscopy, found a slowly bleeding ulcer, treated it on the spot, and he went home the next day. We avoided catastrophe. My advice: that heartburn you ignore can be the fuse of a time bomb. If you take anti-inflammatories, demand a protector. And if symptoms persist, consult. Isn't taking a pill worth avoiding surgery with 25% risk of death? If you're understanding how these emergencies can be prevented, write prevention in the comments. Surgery 3. Emergency bowel surgery. We continue in the abdomen, now in the small intestine. Surgery here is called enterectomy, removing a segment of this vital organ. The common problem, the small intestine, is where we absorb almost all nutrients. Sometimes it gets obstructed, or worse, loses its blood supply. Mesenteric ischemia. Obstructions can be from scars from previous surgeries or stuck hernias. Ischemia is usually from a clot blocking an artery, something common in people with cardiovascular problems. The hidden risk for people over 65. When a piece of intestine dies from lack of blood, it's a race against time. Dead tissue releases toxins and bacteria, causing sepsis and multi-organ failure. The only solution is emergency surgery. Go in, cut out the damaged part, and reconnect the ends. This operation is among the highest risk for people over 65. The connections we make in the intestine, anastomoses, are more fragile in an older, malnourished patient and have more risk of leaks. A leak is one of a surgeon's worst nightmares. It causes another peritonitis and more surgeries. Also, if we remove a lot of intestine, the patient can develop short bowel syndrome, needing lifelong nutrition through a vein, total loss of quality of life. Imagine Carmen, 68, with diabetes and hypertension. She starts with abdominal pain, nausea, vomiting. Could be simple gastroenteritis. She waits 1 day, 2, pain becomes unbearable. She arrives at ER dehydrated and confused. A CT shows disaster, severe intestinal obstruction. In surgery, we find a meter of black, lifeless intestine. We remove it. Operation is a success, but recovery is a battle. She leaves the hospital months later, but is no longer the same. The safe alternative. Again, the key is early diagnosis. The superpower of diagnostic imaging. Faced with persistent abdominal pain in an older adult, we can't wait and see. An abdominal CT can give us diagnosis in minutes, showing obstruction before it's irreversible. Conservative management when possible. Not every obstruction needs surgery. Sometimes we can rest the intestine in the hospital with fluids and a tube and obstruction resolves on its own. Control your heart. Intestinal ischemia is linked to cardiovascular health. Controlling diabetes, hypertension, cholesterol, not smoking, all that is the best prevention. If you have an arrhythmia like atrial fibrillation, it's vital to take anticoagulant that prevents clots that can travel to the intestine. My advice is double for patients. If you have previous surgeries or cardiovascular risk and abdominal pain appears that doesn't subside with vomiting, go to ER. Don't wait. For doctors faced with an older adult with these symptoms, always suspect the worst. A timely CT is the difference between management with fluids and losing a meter of intestine. Surgery 4, late appendix or gallbladder. I know what you're thinking. Appendix on this list, the most common operation in the world? Yes. And also gallbladder, cholecystectomy. The problem isn't the surgery, it's the delay, the common problem. Appendicitis is inflammation of the appendix. Cholecystitis is inflammation of the gallbladder. Both cause characteristic pain on the right side of the abdomen. If not treated, the organ can become gangrenous and perforate. The hidden risk for people over 65. Here's where age plays a dirty trick. In a young person, appendicitis symptoms are textbook. In an older adult, they can be mild, diffuse, without high fever. This leads the patient to think it's just a stomach ache and wait at home. When they finally get to the hospital, the appendix has already perforated, spreading pus throughout the abdomen, peritonitis. A simple appendix by laparoscopy is a walk in the park, 1 hour of surgery and home the next day. But if the appendix is perforated, it becomes major surgery. You have to open up, wash the entire cavity, leave drains. Mortality, which is almost zero in simple surgery, skyrockets. Same with gallbladder. It's the difference between putting out a match and controlling a forest fire. I think of an 80-year-old lady I saw in my residency. She started with pain on the right side, took a painkiller and went to sleep. 2 days passed. Her daughter found her confused and feverish. At the hospital, she was in septic shock. Cause: perforated appendicitis. Despite everything we did, she died 3 days later. If that lady had come to the hospital the first day, she'd probably be alive today. The safe alternative. The alternative is a strategy. Act fast. Immediate diagnosis. In an older adult with right-sided pain, the golden rule is suspect the worst until proven otherwise. An ultrasound, or CT. We can't rely only on symptoms. Early laparoscopic surgery. Once diagnosis is confirmed, the best option is operate soon and by laparoscopy. Delaying surgery is a very risky bet in this age group. Minimal invasion allows much faster recovery, crucial so older people don't lose mobility. Prevention for gallbladder. Obesity and fatty diets increase risk of gallstones. Maintaining healthy weight and a Mediterranean-type diet helps. The advice here is simple. New abdominal pain in an older person isn't normal. It's an emergency until the doctor says otherwise. Don't wait. Don't self-medicate. Is your life or your parents' life worth risking to hold out 24 more hours at home? Surgery 5. Unprepared major surgery. We leave the abdomen to talk about 2 critical surgeries: lung resection for cancer and hip replacement for fracture. The common problem, lung cancer continues being one of the leading causes of cancer death, and hip fractures are a true silent epidemic in the elderly. A simple fall can end in major surgery. The hidden risk for people over 65, these surgeries are risky in themselves. Chest surgery affects lung function. Hip surgery immobilizes you. In an older person, this combination is a time bomb for the most feared complications: pneumonia, clots in legs that travel to lung, pulmonary embolism, and delirium. A hip fracture in particular is a turning point. Statistics are worth thinking twice about. Depending on patients' prior conditions, up to 25 or 30% of elderly people die the first year after fracture. Many who survive never recover their previous independence. Operating on an older person's chest or hip without adequate preparation is like sending a soldier to battle without training or bulletproof vest. The safe alternative. Here the alternative isn't avoiding surgery. A fracture must be operated on. It's radically transforming preparation. This is called prehabilitation. Prehabilitation is a program that starts weeks before scheduled surgery to put the patient in the best possible shape. It's an athlete's training before the finals. It includes supervised physical exercise, exercises to strengthen leg and lung muscles. A patient who enters the OR strong gets out much faster. Nutritional optimization. Many older patients have protein deficits without knowing. A few weeks of supplements can make an abysmal difference in healing. Psychological support. Reducing anxiety and explaining the process can decrease risk of postoperative delirium. Comprehensive geriatric evaluation. A geriatrician evaluates frailty and optimizes all aspects of patient health before surgery. Scientific evidence supporting prehabilitation is solid. It reduces complications, shortens hospital stay, and improves recovery. My patient Pedro, 75, needed hip replacement. Instead of operating immediately, we put him in a 4-week prehabilitation program. He arrived at surgery in optimal condition, started moving the same day of operation, and had incredible recovery. Today he walks without pain. The surgery was the same. Preparation changed everything. My final advice: if you or your parents face major scheduled surgery, don't just accept a date. Ask what we can do to prepare. Is there a prehabilitation program? Be active partners in your health. The best surgery is the one you avoid. At the end of the day, the real enemy isn't the scalpel. It's the afterwards we see, the delay, the lack of preparation. It's not about being afraid of the operating room, but respecting it and understanding that after 65, the rules of the game change. Frailty becomes a key factor, and emergency is always the worst possible scenario. The 5 surgeries we've seen have a common thread. They're the result of a problem that could have been managed better beforehand and less aggressively. The best surgery is the one planned with time and knowledge. Don't postpone that conversation with your doctor, that checkup you've been putting off, that colonoscopy you're too lazy to get, that pain you got used to. They can be the beginning of a story you don't want to live. If this video opened your eyes and you think it can help others, I ask you to share it. Subscribe to the channel for more honest medical advice, like what I would give my own family, and now I want to hear from you. Leave me a comment. Is there any surgery that worries you? Do you have any experience you want to share? I read all comments and will try to respond. Thank you for your time, and above all, take care of your health and your loved ones. It's the most valuable thing we have. I'm Dr. Brad Westwood, and stay sharp.